Hello, hello, and welcome to today's episode of Talking All Things Cardiopulm. I am your host, Dr. Rachel Barisi. Before we jump into today's episode, let's give a shout out to our sponsor, Jane, a clinic management software and EMR. Whether you're just starting to do your research or you've been contemplating switching your software for a while now, the Jane team understands that the process can feel intimidating. That's why their goal is to provide you with all the onboarding resources you need to make the switch as smooth as possible. Jane offers a personalized call to set up your account, a free data import, and a variety of online resources to get you up and running quickly. And if you need a helping hand along the way, you'll have access to unlimited phone, email, and chat support included in your Jane subscription. If you're interested in learning more, book a one-on-one demo at jane.app/switch. And if you decide to make the switch, don't forget to use the code CardioPulm1MO at the time of sign up to receive a 1-month grace period on your new Jane account. Thanks again, Jane. All right, welcome. Happy Tuesday. I'm not sure when I'm going to post this podcast because I do have an interview later today. So we'll see which one gets edited first and up and about. But I just sent out a email to my newsletter and kind of gave a little bit of insight into my intentions for 2024. So if you're not on my newsletter and you are a listener, I'll put that in the show notes as well. My newsletter is something that has been evolving. I've been probably writing to the newsletter for just about a year. And it's one of those things where I sort of share daily insights. It might be something related to cardiopulm. I thought at first maybe it would be more of like a journal article kind of like review, but it's kind of morphed into a little bit of everything. So today I was talking a little bit about my 2024 intentions and what that looks like. And last year I did a podcast on SMART goals. So if you haven't checked that out, check that out. There's always so much hoopla around January 1st and creating goals and intentions and resolutions, whatever you want to call them. I'm not against any of that, to be clear. I am very much a goal-oriented person, but I also don't think that January 1st is the only time to set those goals. 2024 has been like a weird start. We had like the flu right out the gate. I think it was the flu. And then Nikki had COVID like 3 weeks later. And it just kind of felt like we got thrown in and it's March. And I feel like I've been saying this every year, but this is the first time I'm like articulating my thoughts into the abyss. But this year is flying. And I'm like, wow, it's already March 12th. Actually, it's March 12th. Today is my grandmother's birthday. She was born in 1920, so she would have been, 104 today. That woman was a force to be reckoned with, but I should probably do an episode on her because she's a very special person. And see what happens. Every year I usually make a German dinner to honor her, so might have to do that today. But in my newsletter, I was talking about some intentions. So writing is a very big goal for me this year. I have a couple of things I want to do with writing, one of which is writing more frequently to my newsletter. And it might be some of this like mentoring, coaching sort of information, or it might be more journal article review kind of stuff. And we're just going to like see where it goes, because sometimes the creativity kind of spurs as you're doing it. And so that's exactly what happened today. I've been waking up every morning at about 5 a.m. and committing to writing. I have a long-term goal, but I'm not going to put it out into the abyss yet. And so I've just been writing more frequently and kind of getting back into that groove. Growing up, I was a great writer. I was very artistic. And in high school, I don't know if I've told the story before, I had to make a decision between science and the arts. And that was a really shitty decision, because it was like one or the other. I could either choose science because I knew I was going to go into healthcare, right? Like decisions you're making when you're 14 years old that seem ridiculous. Or I can concentrate on my artistic skills, but not be able to take sciences. It was like that was the division. And I think looking back, I'm just I'm so against it because I was taken away from that creative part of myself for a long time. And when I started All Things Cardio Palm, I, wanted a logo and all those things. And so I started dabbling back into drawing. And I realized how much I missed it. Like it was a part of me that I forgot that was a part of me and sort of just kind of, spurred it up. I'm still not drawing as much as I would like. Um, there's lots of things that, like, when you're doing this type of stuff, you realize what you can and cannot do. So, for instance, I just presented at CSM, and if you're doing things correctly in the world of like sharing a picture, you really can't just use any picture off the internet. In academia, I tried to do a good job of, only using copyrighted images and all of those things. But it's difficult. If you were to go to Google and search an image, you're going to get unlimited things. But if you change the settings to what could be used in like a lecture, you're going to get like 5 pictures. So on something like CSM, where it's a national stage and you're, you know, this is like you have to follow the rules. So my partner and I, we were putting together a presentation and we needed a picture of sternal precautions and a clamshell. And nothing was available that could be utilized in this sort of manner. And I didn't have something to use because I didn't have a patient with a recent sternotomy. So she was going to take a picture of her husband, and then I was going to Adobe Photoshop, basically incision lines and such. So we had it as our backup, and we went through the process of asking permission for use from a textbook. It took a little bit of time to get the answer back, but the answer essentially was no. Well, it was yes, but with a really high fee. So we opted for no and we did our own thing. But this has happened before where I hosted a COVID webinar, which that is on my website if you're interested. I'm probably going to update it soon again. But I wanted to depict where the ACE inhibitors are located. And the best way for me to do that was to draw it myself. And I want to teach things like blood flow through the heart and lungs and what that might look like. And I can't just take an image and use it for my own purposes, right? So being able to tap into drawing has been just such an important piece because it just lets other things kind of come to light. Writing is very similar. Writing was always an outlet for me. It was one of 2 ways that I would be able to kind of, things were going on in life. That was my outlet. Sports was the other one. And as you grow up and you're an adult and like you're dealing with all these things and life is life is complicated. Anyone who's listening, you're like, yes, Rachel, life is complicating. Adulting is hard. And you need those outlets. And as we get older, we lose touch with those things. And I'm speaking for myself. If you have been able to keep those things close to you, I am so proud of you because I think it is something that can so easily get lost. So, anywhoozles, I've been writing. And so a couple of things have come up with that. First of all, my writing sucks. I think it's being a PT. Like being a PT, you are writing in fragments at all times. Patient lives with wife. 1-story home with 2 steps to enter. Like there is no full sentence, grammatically correct things going on in a PT note. And we text all the time. And so texting, right? You don't even use the proper spelling of words at this point anymore. So um I just am like noticing, I'm like, wow, I've really lost this skill. And so, how do you improve a skill? You improve a skill by practicing a skill. And so, I've been kind of priming this and doing some reps. And today, when I was writing, I was starting to talk about some of my services, including mentoring. So I offer one on one mentoring for new grads who are starting out in the acute care setting, students who are maybe struggling with cardiopulm in their DPT program or need a little extra help prepping for the MPTE. But I also help prep clinicians for the CCS. And part of what I was writing was I'm trying to get better at marketing myself and the things that I do because this is what I live for and this is what I'm trying to create as part of my livelihood. In doing so, I started talking about mentoring and it kind of just spurred up some things because I've had a mentee reach out to me telling me about like a new job that she had started with, and I asked about her, like, what does the mentorship look like? And I'm just like, I feel disappointed when I hear there is no mentorship. I just have to like pause. Part of what I'm trying to do here in this podcasting world, on my Instagram, on the YouTube channel that I'm trying to now like beef up, is to provide education for clinicians, to provide mentorship. And the reason why this is so near and dear to my heart is because I was a new grad. I was a new grad starting out, and I always felt like I was just thrown in. Like I was thrown into the deep end, sink or swim. Maybe I'll throw you some floaties. Good luck. And that's not how it should be. We are in a beautiful profession, and I know there is a ton of burnout. I know there are a ton of problems in our healthcare system. I 100% understand that the pay scale and all of the things is very frustrating. Um, the more I hear about, PTs in the 90s basically making what people are making now, it feels very frustrating. And so that's a very easy lane to go down, to be frustrated and to have negativity and all of the things. With all of that, I still love what I do, and I am still proud to be a PT, and I know I can provide great care and really help a person get to the next step, to live to be as functional as they can in their current state, to meet the person where they're at, to allow them to thrive in the now. I feel very similarly to mentoring and coaching. And I know I've given my background story before. I was a basketball player. I was a coach. I've been a coach since like I was in the 6th grade. Coaching is just a part of who I am as a person. No matter what setting I'm in, I end up coaching or mentoring or whatever. It just feels a part of me. And so, what I wanted to talk about today, and I think I could probably go down 3 different lanes at this point, but what I intended on speaking about was what mentorship should look like. And I'm going to refer back to basketball for a minute, and I'm going to come back because it's the same. Coaching and mentoring, they're semantics. However, you want to use the word, it's semantics. And it follows the same overall structure. When you have a novice person, a novice basketball player, a new grad, and they are just starting out. You cannot expect that person to know how to do all of the things, to be independent in the space, to know how to make complex decisions. You can go back and forth. In basketball, it might be knowing when to swing the ball, when to drive to the basket, when to throw a pump fake, when to go hard to the basket and take a foul versus passing to no one who's open, right? It might be flashing the middle to get open for a press. And I just have my niece's basketball team like front and center. In PT, it's the same thing. Whether you know a precaution, understand a line or tube, know how to deal with a family member in the room, know how to divert conversation when it's going in the wrong direction, know how to articulate to the physician your concerns, know how to make a decision on green light, yellow light, red light, and hold true to that. When to be safe, when to pull back, when to push. It's the same. And the process of getting the person there is the same. When you have a novice person, you need to have a period of teaching. In the PT world, it starts with DPT school, right? Before they're clinicians, they're a student, and they spend 2.5 years learning a lot of information. That's base. Just because you went to PT school doesn't mean that you are proficient in every line and tube, every precaution, every diagnosis, every decision that needs to happen. That takes time, it takes mentorship, and it takes making decisions with guidance before you do it on your own, right? A good coach teaches. A good coach teaches you fundamentals. Period. Fundamentals are fundamental. If you don't have the basics, you cannot do the next thing. In basketball, that might be dribbling or passing in a static position before you can dribble and run, dribble and shoot, right? Fundamentals are fundamental. You have to have a component of teaching. In the acute care setting, for instance, that might look like orientation to a unit. What are the basics? If I'm on the ortho unit, I need to know my precautions per surgery. I need to understand the difference between an anterior hip, a posterior hip, and a lateral approach. I need to know that the precautions are different for all three. I need to understand why the precautions are different for all three. Maybe I need to understand the surgery, where they're accessing from, because that's going to lead to the precautions. Where are they most likely to dislocate? Maybe it's understanding anesthesia. Post-op day 0 was something that was brand new 14 years ago, and I was a part of that. I was also part of making feasible plans for the therapist seeing those patients on day 0. What does it look like? When is your patient going to be ready? In how many hours time post-surgery? Creating efficiency with those plans, because there are things that are going to happen. Expectations with someone who comes out of general anesthesia and the time frame, spinal anesthesia and the time frame, and what to look for to know if your patient's even going to be ready, quick and dirties, and epidurals. What to know, what to expect, what to monitor. And if you don't know those basics, you're going to put your new staff in big trouble. Lots of people want to say there doesn't take skill to be on ortho. I highly disagree, especially with how fast things are moving on ortho units. You need to have a thorough evaluation, be able to educate your person, make quick decisions on discharge, and potentially teach family members how to do all the things, because you don't know if your patient's going to retain the information. You have to be able to make hard decisions. And sometimes those decisions include standing up to physicians and saying, this patient is not safe to go home from my perspective, and not changing notes because people might want you to say they're safe. At the end of the day, it's your license. This might be a little hot topic. This might be a little touchy for some people, but at the end of the day, it's your license. And if you're not mentoring your new grads on what to do, what to expect, things could happen. Just saying. So you have to teach. You have to educate. What are the surgeries? What are the precautions? What are the lines and tubes? What anesthesias am I going to see? What should I expect? What should an evaluation for this patient look like? That's a very simple piece. I asked my mentee who just started a new job, I said, was there any like workflow information? No. What does that even mean? What is the anticipation of what your day looks like? Chart reviewing, number of patients, units expected, the flow of the day. What does it look like? That's a basic. Mentorship should be a progression. It should start with education, the basics. These are the things you need to know. It's going to look different on the ortho unit versus the cardiovascular unit versus the pulmonary unit versus the neuro unit. And just because you're oriented to one unit does not mean you are competent for all of the units. Mentorship is a progression. And sometimes it's going to ebb and flow from the beginning to an end where the person's independent, and it's going to come right back. That's what mentorship looks like. Learn the fundamentals, teach the fundamentals. Then there should be a showing component, a demonstration. First you educate, then you demonstrate. Okay? The person needs to see what the expectation is. What does an eval look like? What does a transfer technique look like? What does bringing the patients to the staircase look like? What does speaking to the NP, PA, physician, nursing team look like? What does collaboration look like? What does handoff on discharge to social worker case management look like? They have to see, they have to observe it. And then you flip the switch. The new grad, the novice, is doing the things, but that mentor is with them to help guide, to be a just in case. They're in the moment. Now they're making the decisions. Did they make the right decision? Are you there to help them, guide them to make the right decision, to prevent something from potentially happening? Then you back off. Then it becomes supervision, where I'm watching, but from a distance. When you have passed a competency, whether that is a test, a physical evaluation where someone's checking you off on all of the things, assessing vitals, giving the appropriate education, giving the appropriate handouts, understanding all the precautions, appropriately handling lines and tubes. That's meeting competency. Then you still don't throw them out into the wolves. Now you're at like FAR supervision. Now you're the checkpoint. Hey, I had this situation. I haven't come across it before. What do you think? It's a collaboration. Okay, mentorship is a progression. It might start all over again when it's the next unit, the next skill, whatever it is. But sending a new grad, a novice, out into the abyss and saying good luck is not the way to go. risk for things going wrong, risk for poor collaboration between interdisciplinary staff, having your novice get steamrolled, and then that affects other things down the line, including maybe the PT who is standing up for something, right? It has to be on the same page. There should be some sort of equity across this mentorship. Everyone should have the same process. Everyone should have the same education, regardless of what school you came from, because it puts everyone on the same playing field. You're playing in the same game. If this person's doing one thing and this person's doing another thing, and that person's doing something completely different, what does your PT department look like? What does the rest of the hospital see? You have to be on the same page. Competencies, mentorship gets you there. And it's good for everyone, including the seasoned clinician who is now relearning how to coach, maybe looking at the information from a different perspective. It's going to help across the board, but you have to provide time for that to happen. If the goal is mentorship and competencies, you have to allow the time for that. And what that means is the person who is mentoring the novice can't have a full caseload and expect the novice to have a full caseload. It doesn't work that way. Two become one for a short period of time. And that's going to decrease the number of problems you have long term. Mentoring is a progression. When I was a new grad, I'll tell you about my first day. My first day was like a hot mess academy. So when I went into acute care, I had never had an acute care affiliation before. I had had 2 sniffs, and one of the sniffs sort of had an acute setting, but I wasn't really a part of it. I think I maybe saw 1 or 2 patients with the CI. And that was actually one of the places, I should probably talk about my affiliations at some point, where there was no mentorship. And you just thrown another place, you're just kind of like thrown in. Sometimes you learn, right? Some people, you make a choice, you sink or swim. Some people swim. But why does it have to be so hard? So anyway, first day of my acute care job. Reflecting back, this is actually, I don't know if I've ever told this story. Reflecting back, there's another story on top of the story. And if you haven't met me, this is how stories can go sometimes. Okay, so today is grandma's birthday, which is actually interesting that I'm talking about this today. When I started my acute care job, my grandmother had recently been diagnosed with stage 4 cancer, and she had a massive abdominal surgery. She was in the acute care setting for a short period of time. Was tenuous for a minute, like it was a big surgery. She was in the ICU. They had to do a second surgery. She ended up with a colostomy and an ostomy, like a fistula. And she went to sniff. And I was kind of a part of this process while I was sitting for my PT exam, starting my first job. And so by the time grandma was home, we basically got her out of the sniff at one point. She was doing enough to be safe at home when I wasn't home, and we had to get her out of there. We just had to get her out of there. I was teaching the nursing staff how to do colostomy changes at one point. So when we were able to get her out, we got her out, and we wanted her to be home with us. And so I would do the night shift, and my mom would do most of the day shift. And, I'm doing colostomy changes and bed baths and transferring and all of the things before I start my first acute care job. So the morning of my first day, Um, I slept through my wake up in the middle of the night and check on grandma alarm. And when I got up, I was behind schedule because I had to check on grandma, change her colostomy, maybe, hopefully not, um, and, do whatever. So the day before this, hospice nursing finally came in and they did her first colostomy change at home. And it didn't it didn't stick, literally. So the next morning when I came to check on her, her ostomy had spilled out everywhere, and including into her incision. So the ostomy team didn't leave a ton of materials. So I had like, I want to say 3 gauze, some saline, and a fresh colostomy. I don't remember the words now. Basically, the stickum that goes to the colostomy. Now, side note, grandma was very small. She was a small frame anyway, and she had already lost a ton of weight. And so getting a good fit on the colostomy was difficult because it was right around her rib cage. And so if it wasn't prepared correctly or well, it was going to spill out. And she had a pretty significant abdominal incision. So I'm starting my first day at the acute care setting, which I have to take a subway to get to. And grandma's colostomy had spilled out into her incision. So I removed it. I got her cleaned up and then, got the stool out of the incision. And basically, with 3 gauze pads, some saline, and a new colostomy, I got her incision cleaned up enough and covered, and a new ostomy placed for the hospice nurses to come in. Now, there was like an emergency hospice line. Um, Very interesting if you've ever had hospice in your house. It's a little bit more hands off than I thought it would be. So anyway, mom had to deal with getting the hospice nurses in, but I couldn't leave her knowing it could be hours before they came. And I'm glad I didn't because they didn't make it there until like 12 o'clock. And this is 6 o'clock in the morning. So that was the first day of my acute care experience. I'm a new grad. I had been working on a temporary license at an outpatient physical therapy place up until this point. So this is like my first big girl job, my first full-time position. And this was the start of my morning. And I remember just like getting myself dressed and like booking it to the subway and coming in and feeling a little frazzled, right? So, first day of work, it should be observation. I should just be following someone around all day, like learning the ins and outs, getting the tour, learning maybe the documentation system. And that was kind of part of the day. I was paired up with my supervisor at the time. And there were just like so many things that happened this day that sometimes I look back and I think this was a wild first day. So I think one of the first patients we saw together was in the ICU. So I worked in an orthopedic hospital. So the ICU was only like a 9-bed unit. And then we had a step down unit, which was like a 4-bed unit. So needless to say, now having worked in like big university hospitals, this is a very small ICU with, not that complex cases. There were complex cases, but not like the ICUs I work in now. So, first patient of the day is a patient who was a TBI patient who was transferred up from our acute rehab. So this hospital had an acute rehab within the hospital. And so this patient had been transferred to the ICU. So my supervisor was treating him. And I just remember him asking me, what do I think? Like right out the gate. And I was like, so let me give you a little backstory. So patient had a TBI. He had a craniectomy. And I don't believe, if I remember correctly, that he had his helmet at the bedside. We also didn't really do a significant chart review before seeing him. And the what he wanted to do was transfer the patient to a bedside chair. And he asked me, "So what do you think?" And I was like, he, his exact words were, "He looks light. I think we can get him to the bedside chair." And I just remember having the guttural reaction of saying, "Wait a second. Maybe we should find out a little bit more about this patient, like what his sitting balance is, what he was working on in acute rehab. Does he have a power chair, a tilt in space? Does he have a helmet that he should be wearing when he's out of bed?" I don't know if putting, and this is me being like passive, right? I don't know if putting this patient in a regular chair at the bedside is the safest thing to do. And he kind of was a little taken aback, and I was like, "Why don't we call the therapist downstairs? Like, is that possible?" And he's like, "Oh yeah, that's possible. Let's do that." So, needless to say, the patient had a tilt in space wheelchair. He needed to have a helmet. His sitting balance was like max of 2. Putting this man in a chair could have been disastrous. He could have just slid out. So that was my first episode. And then my second episode, um, we went to see a patient, and I don't remember if it was a hip. I feel like it was a hip, a posterior hip. I can see the room, and these are like core memories at this point because I remembered thinking, this is not how an orientation should go. And if I ever am in a place where I can mentor, I will never let my mentee feel this way. And I'm like 30 minutes into this position, and I'm already having to make really big decisions. So we went to see this patient. Patient, we'll say, had a posterior hip. I'm observing, right? So at this point, I'm in that he's demonstrating, I'm observing, I'm learning what to do. And what I felt like was I was learning what not to do. And I learned these things very early in my career. And when I became part of orienting, I made sure that other things were included. So he got this patient from the bed to the chair, and I'm just standing watching the whole thing happen. And he walks away from the patient to get something. We had these like bathrooms that were like in a nook behind where the patient beds were. I can like see this room very clearly. And I noticed the patient's like really lethargic and is going to pass out. Like I'm watching it happen. And so I call him and I tell him, "Hey, she's not looking so good." And he kind of was taking his time. And I just remember turning on the sink, throwing a towel in the sink, and dousing this woman with water. And she came to. And then we max assisted her back to bed. And I remember thinking, wow, I think we could have avoided that. And then there was a third person, And the third person, again, I remember this very clearly. It was on the 11th floor. I don't remember what the surgery was, but the woman had a glass eye. Didn't know she had a glass eye. These are things that matter, and why chart review is matter. Was that English? Why chart reviewing matters? Because there are things that you are going to learn about a patient that would be helpful before walking into a room. Knowing the patient's prior level of function, especially if they came from acute rehab, knowing if they were utilizing a helmet, knowing if they were in a tilt and space wheelchair. Those are things that you would know before even walking in, which helps you make a decision in the moment. Taking vital signs on that second patient. There were no vital signs taken. If we would have taken vital signs and assessed orthostatics and maybe have gone slower with the technique, the patient likely would not have passed out. And then the third patient had a glass eye. The reason why this matters is because when I walked into the room, the patient was sleeping, but she had a glass eye. So the eye was open, but it looks like nobody's home. I didn't know she had a glass eye. So again, I was kind of left in this episode, and I go to wake up the person to make sure that they're like, okay. And then she woke up and I was like, oh my God, I almost had 2 syncopal episodes or maybe worse in like less than a 30-minute bout of time. And after this day, like day 2, I was just given a caseload. So did I learn a lot of things on that day? Yes, I learned so many things. I learned what not to do very quickly. I learned what kind of mentor I wanted to be very quickly. And I learned that I was going to have to do a lot of learning on my own to be a safe clinician in a certain setting. And no one should have to go through that. That is not how you set up your staff for success. It starts with education. It starts with developing a strong team, whether that's through in-services, lunch and learns, continuing education, allowing clinicians to develop, allowing clinicians to pursue specialties and supporting those specialties. And I want to be very clear about that, because if we're not supporting specialties, and maybe that includes a grade level in your every place is different. So I have like the VA in my mind. They had step levels. And if you got a specialty, you increased a step, which led to an increase in salary. And that's important. Like, I don't know if anyone is living in this world right now, but this life is expensive and you should be allowed to be paid your worth. Support your staff. And then that staff will nurture the novice staff. And when you have that relationship, that's how you have a strong unit. That's how you develop good culture. You have to promote education, learning, collaboration, standing up for your profession. So what can mentoring look like? It should be education, demonstration, observation, feedback, and then guidance along the way. But you can't start with guidance. You can't start with just being a check-in, because unless you know that new staff member has the information they need to be successful, you're going to be playing catch up the whole way, and could potentially have detrimental things happen. Set your staff up for success. Set your novice PTs up for success. Mentor them. Have some sort of competency for every unit that you're going to. Do checkoffs. Make sure your staff is competent. And if you don't have mentorship, seek out a mentor. It will make you a better clinician. It will allow you to become a mentor in the future. So I'll put one last plug in. I probably went way off topic, and I still don't think I hit all of the things I wanted to, because I just was talking and not following my outline over here. But if you are a novice PT, if you're in the acute care setting, if you are looking to sit for your CCS and you are looking for mentorship, I do that. I do one-on-one mentoring. I can do one-off calls, or if you're doing something like sitting for the CCS, I can do a monthly type of mentorship. And I have done it before. I have had my most recent mentee passed her CCS last go round. We celebrated her CCS at CSM. And I've had another person who wasn't doing their CCS but needed the same type of mentoring where it was not just going to be a one-off call, it needed to be a monthly kind of thing. So I am very much a person who believes that mentorship looks like coaching, and every person needs something a little bit different. And when you have the ability to not critique, you have the ability to, what is that word? Um, Not cater. You have the ability to implement specific mentoring for your person. That is the best way to go about. If you're not looking to do a residency, but you want someone to take you under your wing, you want to learn the why behind what you're doing, you want to understand the physiology before you implement. Yeah, you can absolutely do that on your own. And I encourage you to read articles and get back into the textbooks. But if you want guidance along the way and you want someone to help you build that clinical decision making or prep for that CCS exam or start in faculty, like lead up to that piece, whatever it might be, set up a discovery call. I would love to chat with you. I would love to mentor you. And I would love for you to continue so that you can eventually mentor somebody else. All right. I will drop my contact information, my mentoring links down below. And thank you for listening. Thank you for listening to my soapbox. I hope this hit home for you on either side of the coin. So, love the feedback. Send it my way. If you have any questions, please reach out to me on the Instagram or shoot me a text in the number down below. And as always, have a wonderful day. And whatever you have to do, get after it.